There you are.
There I am. Good evening, everyone. My name is Leslie Brooks. I'm the Director of Professional Education at Implement. I'd like to welcome you and thank you for joining us tonight webinar with extraction and socket preservation techniques to increase efficiency and improve clinical outcomes. We're excited to have Dr. Matthew Fine with us, a leading expert in the field, who will be sharing his insights and practical strategies to help you achieve consistent results. Dr. Fine graduated from Columbia University College of Dental Medicine. He then received his specialty training in periodontics from Nova Southeastern University and his diplomate status from the American Board of Periodontology and Implant Dentistry. He is an active member of the American Academy of Perio and the Academy of Osseointegration, and maintains a private practice in Fort Lauderdale, Florida, with a special focus on hard and soft tissue regenerative and implant dentistry. Dr. Fine has been published in various well-respected dental journals, such as the Journal of Periodontology, the Journal of Oral Maxillofacial Surgery, and Compendium. In 2017, Dr. Fine co-developed a series of hands-on guided bone regenerative and soft tissue management courses, which he teaches throughout the year. Please join me in welcoming Dr. Fine. Dr. Fine, the floor is yours.
Amazing. Well, it's always fun to work with Leslie. Um,
Thank you.
for those of you that haven't seen me present before, I'm really excited about this presentation. I can't thank Leslie and Implement enough for inviting me, because this is one of those topics that, I get so many questions about on a daily basis. How do we start bone grafting predictably? And one of the ways that I find for young clinicians or even those with experience to really become more effective in the office, to have less stress, and to be more productive and make more money, to be honest, is to get really comfortable, not only with socket grafting, but also extracting teeth. I think that is something that is not really taught all that well in dental school. And a lot of us come out and we maybe take an implant course and we start placing implants. But the reality is, implants are the easy part, right? It's all about having the available bone and good, healthy bleeding bone, that allows us to perform predictable treatment. And so for those, again, that haven't seen my presentations, I tend to be very clinically based. We're going to see a lot of cases. And even though, we did sort of decide that we're going to really start at the beginning with extraction and socket preservation, for those of you that maybe are a little bit more advanced, I will be sharing, some of my, favorite tips and tricks that I use for ridge augmentation as well, because I think it really does go hand in hand. For housekeeping purposes, you guys should all know that none of the photos have been altered at all. I'm receiving an honorarium for the presentation, but I have no financial interest in any of the products or any of the materials that you see here. I really find that, for me, I really do enjoy sharing this material and sort of, explaining to people my philosophy on, how to best treat patients, not only from a patient management perspective in terms of not having complications and reducing morbidity, but also, I went through, a phase in my career where I was very stressed out, where I had too many materials to choose from. There were so many different decisions that you have to make along the way, and that created a lot of stress for me. So once I sort of figured that out and got to a point where I was more comfortable, I really do enjoy sharing, what I've learned over the last 18 years or so. And so again, thank you all for joining us, and I'm going to be very excited to hear if you guys have any questions later. This is why we're here, right? Management of extraction sites. And this was a case that was referred to me about a month and a half after the patient had the tooth extracted. And I'm not being critical of the doctor that extracted the tooth. The patient actually had a very traumatic fall. He was playing hockey, and he slipped and head hit the ice. And the tooth took the grunt of it. The treating clinic, doctor doesn't do bone grafting, but he's a very good doctor, and he made the patient cantilever temp, as you see here, and then the patient ends up in my chair. And, this is a case that we can certainly manage with bone grafting and maybe even some soft tissue grafting, but it really highlights why we do bone grafting or why we really should try to do socket grafting when we take teeth out. Because you can see we've completely lost the root prominence. We've lost that contour. Whether or not there's going to be enough bone to place an implant when we go back, we're going to find out in a couple of weeks when we take a CT scan. But we know that we've lost, contour here. And so that's really the focus is learning how to preserve the soft tissue and the hard tissue contours. And the best way to do that is to be as minimally invasive as possible, meaning that we want to learn how to take out teeth as atraumatically as possible. And we want to learn how to regenerate bone, but more so, we want to preserve the bone that's there. It's much easier to preserve what's there than it is to try to regenerate it. But in order for us to really have a talk about how we're going to do that, we do all have to have a good understanding on how the body heals once we take a tooth out. And this was a case where the patient actually declined bone grafting. And as you can see here, there is plenty of bone to place an implant now. And that is what will happen. When you take a tooth out, we degranulate, we remove any infected tissue. And what happens? If we have good anatomy, especially and wide bone, those defects will fill with blood clot, and that blood clot will turn into bone. But as you can see, you will get some resorption. And one of my mentors used to always say that the problem with doing, oral surgery or periodontics or any, surgical field in this manner is that we don't know who to treat. And after doing this for 18 years, I can tell you there's many cases where, I don't necessarily bone graft because maybe the patient has a very severe infection, maybe they're suppurating, and other reasons, financial reasons on the patient's behalf, or maybe the patient just has really thick bony anatomy. And those cases do come in, but that's not the majority of cases. The majority of cases that we see are patients, first of all, who are having teeth extracted because either the tooth has a failing root canal or a fracture, and usually they have bone loss to begin with. And so that's very important to keep in mind. But really what we want to do is we want to allow the body to do most of the healing without creating unnecessary trauma. And it is pretty impressive to see how the body will heal. It's almost unbelievable to me that when you take a tooth out and you're staring at this really large socket, this really large hole, how the body knows to heal. And it does that because it bleeds, right? Bleeding is good. And that's going to be very important when we start talking about socket grafting, making sure that we have a nice, healthy bleeding socket. But the reality is, again, that clot will form granulation tissue within about a week. And even when you look in these patients' mouths after about a week, you'll still see the residual socket, but soft tissue will migrate over that socket about a millimeter a day. And it's pretty impressive to see how the body will do that predictably. It's very, very uncommon for bone to be exposed in the mouth. The body does not allow bone to be exposed. So unless a patient's on some sort of bisphosphonate medication or maybe some sort of medication that's altering their healing, the body will form soft tissue and grow that soft tissue over that socket. And in about 8 to 16 weeks, we start to have mature bone. And so it's important to understand we're not, as periodontists or oral surgeons or general dentists that perform this procedure, we're not really responsible for this process. The body wants this process to occur. But what you have to understand is that when we take teeth out, the body knows the tooth's gone as well, and it doesn't need bone. And so it starts to resorb the bone. And once the bone resorbs, we also usually get a soft tissue defect as well. And again, it's all about we don't know who to treat. And so while there are some cases, which I'll show some examples of, where I don't graft necessarily at the time of tooth extraction, the majority of my cases I do because it's much easier to preserve than it is to regenerate. And you'll see lots of variety in the amount of resorption that patients, undergo during those first 4 to 6 months following a tooth extraction. And it's very common for them to present with a horizontal ridge defect. Vertical ridge defects typically present because patients have very severe bone loss even prior to the extraction, or maybe had a very rough extraction, a lot of iatrogenic trauma. And that's why I like to also discuss, how best to take out teeth as atraumatically as possible. And some of the tricks that I've learned over the years that have really changed my practice because I've gotten so much better at extractions. Now, the reality is a lot of my practice is bone grafting and ridge augmentation. And I think it's important to mention that, this is and has become a very predictable modality. And we're going to talk about this a little bit later, and I'll give you a little insight into that. This is doable, right? This can be a very predictable procedure, and I'm not a big fan of using non-resorbable membranes. I use a ton of resorbable collagen membranes because I've learned how to stabilize membranes. And for those that haven't heard about my technique that I do pretty much every single day of the week, I like to call it the rib roast technique. And what we're basically doing in this technique is we're augmenting the ridge by using, particulate bone graft mixed with some autogenous bone. We're laying a resorbable collagen membrane over the graft. But for those of you that have never heard of this, it's called the PASS principles. The PASS principles are principles, the four principles that we know we need in order to successfully regenerate bone. And it's very important when we're doing ridge augmentation that we satisfy those PASS principles. So it's basically an acronym. So the A stands for angiogenesis. We need really good blood supply to the defect. And you'll see in this picture, we have intramural penetrations into the buccal plate. And that's because we want blood supply to our graft. As I just mentioned, I also like to harvest some autogenous bone, and that helps me with angiogenesis too, getting some live bone cells into the area. Then we need to maintain the space. And this is very tricky because most of us are using particulate bone graft for this. And particulate bone graft, while it can congeal with some autogenous bone, or maybe we can make sticky bone to make the handling better, it really doesn't have any resistance to collapsing. And so what I like to do is I like to stabilize, which is the next pass principle, right? Stabilization of that membrane. And we can do that with either screws and tacks, or as we see here, I can do that with sutures. And so for those that want to learn more about this, stay tuned towards the end. I'll show you some great videos on how to actually do this. But when we're performing this procedure, the PASS principles, the P of the PASS principles is we need to get primary closure. And that can be a very traumatic experience for patients because in order to get primary closure, we have to do a internal periosteal releasing incision. And again, I'm going to show you how to do that as minimally invasive as possible later on. But at the same time, no matter how minimally invasive I like to feel that I'm being when I'm getting primary closure, just by the nature of pulling everything coronally, you're moving the mucogingival junction, you're stretching the tissue, you're making it thinner, and you're creating a lot more swelling and morbidity after the procedure. And so as a quick example, I'm using a lot of this pericardium membrane. This is the OsteoFlex membrane. This is an incredibly easy material to use. And why I love it so much is that we have a lot of different ways that we can stabilize this membrane. Okay. And so this is just a sort of a sneak peek into, some of the types of grafting that I do here. But this is a case that was referred to me. The patient had an old FPD that they were planning on replacing, and they really wanted to get into single units. And of course, as you saw in the previous picture, the patient had nice thick tissue, and that can be very, very deceiving because when this tooth was extracted years prior, it wasn't grafted. And as you see from the intraoral view, the bone started to shrink. And again, what we lose is not only the soft tissue contour, even though the soft tissue had nice tissue quality, we lost the contour of that root eminence. We see that we've lost that bony contour. And in order for us to place an implant and have it be not only functionally correct, but also aesthetically correct, we need to regenerate this. So I'm using this pericardium membrane, and I'm going to show you exactly how we do this later. But just to show you, this can be done very, very predictably if we're following the PASS principles. I'm getting primary closure over this stabilized, I like to call it the graft membrane complex. And this membrane has shown to be very biocompatible. I have very few instances where I ever see this membrane get exposed following treatment. We have no inflammatory reaction because the membrane is not cross-linked, and we have beautiful healing. After about 5 months, we can re-enter the site, and you can see my bone does not look like particulate bone graft. It looks like it's turned over, it's healthy bleeding bone, and that's what allows me to place my implant in that prosthetically driven position, knowing that I'm satisfying what we like to call the critical bone thickness. And what that means is we know, from years of research that if we have less than 1.5 millimeters of bone on either side of that implant, buccal or palatal or mesial or distal, we have to worry that we're going to have a much higher chance of having, bone resorb, implant thread exposure, and whatnot. So it's very important for me when I do place implants that I have this available bone. Now, like I'm showing you here, it is very possible to do this procedure, but the more of these that you do, the more that you realize that it does come with a cost, just like everything in life, not only from the financial perspective of more expense for the patient, more expense for us in many cases because of the materials needed. But time is money, right? And this takes usually 4 to 6 months to heal. And as much as I like to talk about minimally invasive treatments and how I feel like I can, do a periosteal release and get primary closure without causing too much trauma, I still have patients. I had one today that presented, following a bone graft that I did a couple of days ago, very swollen, black and blue. And the reason why is because inherently that procedure will cause that morbidity. There's just a lot going on, and it's technically it's periodontal plastic surgery. So, when we do these cases, we can get great results, but you have to understand that if you're relying on going back later to do ridge augmentation, there's a lot of things that can go wrong. And there's been plenty of studies to show that once we start doing reconstructive surgery, especially guided bone regeneration, we are at risk of having compromised aesthetics in the final result. And again, the reason for that is because we've now pulled everything forward. We pulled everything coronally to get primary closure. And this is many times what these cases look like following ridge augmentation. So I'll take a CT scan and I'll be very proud of myself that, wow, I regenerated all of this bone, but I've also moved the mucogingival junction, and that has to be accounted for. And we have to then go back and do a soft tissue grafting surgery or some sort of apically position procedure if we have enough tissue to work with. But this is not an easy thing to learn. And it took me many years to learn how to, appropriately fix these cases once we've created this sort of a defect. You really can't get that experience until you start regenerating bone. And then you realize, wait a second, the bone grafting was actually the easy part. The hard part is creating the soft tissue. And so I am not alone in this. Everybody, this is a known thing that it's much harder to create those natural contours once we've moved the mucogingival junction. And so the focus of today is really going to be how do we maintain hard and soft tissue contours without having to rely on these regenerative procedures. And I will tell you, if you've never heard of this technique, this dual zone therapy, this will change your practice. So this is just a perfect example of how I'm going to be treating most of my cases, especially in the anterior, where I'm going to try to extract my teeth as atraumatically as possible without raising a flap whenever I can. I can usually place an implant immediately because regardless of any, position of the tooth issues, maybe buccally positioned, or maybe even if I have a buccal plate defect, it's almost always possible to get good primary stability into the available palatal bone, especially with the fact that most of the implant companies now have a tapered, aggressively threaded implant. And so getting primary stability is usually not an issue. And the beauty of this is that if I can get that implant to be stable, I can actually fabricate a immediately immediately temporized crown. I don't like to call it an immediately loaded crown because I do keep these out of occlusion, but I can fabricate this provisional. In this patient's case, I use the crown that the patient actually came in with and use some composite to create the emergence profile. And as you see in the bottom right-hand side of the screen, this is how the patient goes home. So people ask, well, does this patient get bone grafted? Yes, they do. You can see around the implant, we have a defect, right? And so that's sort of what we like to consider the subcrestal zone. So I will bone graft that defect. And then before I put my temporary in, I'll also add more bone graft around that emergence profile. Not that that's going to turn into bone, but it does help to maintain the space so that, soft tissue can heal appropriately and not collapse. And this is called the dual zone technique for those of you that haven't heard it. So why are we doing this? Well, number one, the body is ripe for healing at the time of tooth extraction. We have great bleeding. And as you notice here, I didn't have to use a membrane. There was no buccal plate defect. The patient had nice anatomy. We were able to get the tooth out atraumatically. And so there's no need to elevate the flap or even using a tunneling spoon to elevate the periosteum off the bone. We don't want to do that. If we do that, we're just cutting blood supply to the buccal plate, and we're most likely going to have some resorption. And then you notice there's no sutures either. So these patients are probably the best practice builder that I have, because these patients go and brag to you about their friends. They don't have to wear it temporary. Okay. And what happens when they come in 4 months later is that you've maintained what they have. And this is, straight from Dennis Tarnow's mouth. If it's there, you want to leave it there. You don't want to make incisions if you don't have to. And this is really proof of principle in this case, because we have that root prominence that's been maintained. We didn't do a soft tissue graft here. Granted, this patient had nice anatomy. He was a perfect patient for this treatment, philosophy. But look how beautiful this can heal with no surgery. I mean, this procedure literally took 10 minutes to take the tooth out, clean the socket, and place the implant. Maybe it took another 20, 30 minutes to create the temporary. And those of you that are out there that are, a lot more digital based than I am could probably 3D print a temporary a lot quicker than I actually, take to make it. But regardless of how you're going to create the temporary, you can actually preserve the patient's anatomy without having to rely on, soft tissue grafting and large augmentation. And so I think it's very important to understand that if we can preserve what the patient comes in with, we're going to be a lot more predictable long term. And, thinking about these types of cases, obviously not every case is going to be a good candidate for this. Why is that? Well, I mentioned earlier, we don't take out healthy teeth. The reason why we're taking out teeth is typically because these patients have either a fracture of the tooth or a failing root canal, or maybe decay that goes below the crest, which makes maybe even a little bit more difficult to get the tooth out. But what I can tell you from my own experience, and this is, picking on myself, early in my career, I made my life a lot harder than it had to be because I created a lot more iatrogenic trauma than I needed to. And that was because I didn't section teeth enough. I just kind of blindly would try to, loosen teeth up, maybe use, a small luxating elevator, which could also, of course, cause trauma to the adjacent teeth. And then I would just very haphazardly, use forceps to extract teeth. And very commonly, you would end up with a large defect. And now, all of a sudden, the case that went from a very straightforward case becomes a much more complicated case because I really wasn't as effective in extracting teeth as I needed to be. So, the best two tips that I've ever gotten years ago was to never begin extracting a tooth until you can initiate some degree of mobility. And what I mean by that is that, when we're taking a tooth out, typically, you're going to want to take that tooth out as quick as possible. We kind of want to rush to get the tooth out, but you have to take a couple of minutes. First and foremost, I will use a 15C blade. Okay. And I will use that, and I'll show you how I do it in a second, but I will use that. I'll place that within the sulcus and I'll walk my way around the sulcus. And that's doing two things for me. Number one, I am severing that PDL. Okay. I'm severing that attachment, but I'm also using it almost like a periotome. So I'm kind of walking my way around that sulcus and I'm kind of feeling for any mobility of the tooth. And then you have to be really patient. If you put a little bit of pressure on the tooth in either direction, or maybe even with like a luxating elevator or something very, very thin that can get within that PDL space, you can start to see whether or not you've initiated some mobility. And I will tell you, in my experience, the old saying is very true here. Slow is smooth, smooth is fast. And if you try to go too quickly and you just grab that tooth with a forceps and start, twisting it and rotating buccal lingual, you're going to end up blowing out the buccal plate. You may end up with like a soft tissue dehiscence because you haven't really, isolated the soft tissue from the tooth. And I have many cases that get referred to me where general dentists in the neighborhood will start extracting a tooth and they hit a roadblock. They can't get the tooth out. They're unable to effectively get the apex of the root out, and they send the patients over to me. And in almost every one of those cases, those patients, they call up and they say, "Can you squeeze the patient in?" And I always say yes, of course. And the reason why is because I know that it's going to be very easy. Why? Because the patient's now been sitting around for 30, 40 minutes after, the tooth's already been pushed around. So there is an inflammatory process that occurs. And I think it's hyaluronic acid that fills up that space. And actually, if you just take a couple of minutes, the tooth will then pop out usually very, very easily. And so, again, for demonstration purposes here, just to show you, we're going to use this 15C blade and we're just going to put really firm pressure very carefully, trying to feel that PDL space, walking my way around the tooth. Now, for those of you that, are fresh out of dental school, maybe you're using, ash forceps more than I was when I first graduated. But I remember getting into private practice and I would basically have an anterior forceps on my tray and maybe a 150 and a 151. Then I learned about the ash forceps, or I should say, I relearned about it, and it really makes a lot of sense. And I'll show you that in a second for those that can't visualize what that instrument looks like. But if you look at the roots of the teeth in the mouth, almost every single one of the roots are tapered roots, which means that they should be able to be extracted very easily with rotation. Now, of course, there's some exceptions to this. Maxillary first premolars often have two roots. Um, molar teeth obviously usually have tapered roots, but oftentimes they go in different directions. So I usually will section first, and it's very difficult to use an ash forceps effectively in the back of the mouth. But especially for my premolars and anterior teeth, using an ash forceps is by far the most effective way to get these teeth out atraumatically because each of the roots of the teeth are tapered. For lower premolars, especially, I will oftentimes section the contacts first to allow for some rotation. But the reason why this is the most effective tool is because it's really the only forceps where the moment arm is perpendicular to the working length of that instrument. And you can imagine if we're using a 150, like you see in the right side of your screen, any rotational forces that I'm creating is just being created with my wrist. Whereas I'm using an ash forceps, I'm able to rotate with my shoulder. And so I like to use one with, a nice small beak. I'm not a huge fan of all these different, fancy instruments with all the teeth. Sometimes it is valuable to have one with some teeth for gripping a tooth that's very difficult to get a handle on. But the reality is, most teeth, once you use that 15C blade, even for a tooth like I just showed you, that was, basically completely fractured at the soft tissue level, once I'm using that 15 blade to just gently feel my way around that PDL space, I'm now separating the soft tissue from the tooth so I can fit a small beaked ash forceps into that area. And that allows me to get these teeth out very, very atraumatically. Now, of course, we always run into problems. Not every case is going to be so straightforward. And so has to be by far the best thing I've ever learned in dentistry. And I also learned this from Dennis Tarnow. This is an 859 diamond burr. This is the longest, thinnest diamond burr you will ever find. And what it allows me to do is to open up that PDL space, and to section teeth if I need to, and to create a little moat around a residual root that I can't get access to. Okay. And so there's really no tooth that I can't extract if I have this tool, because even if that tooth fractures very, very apically, I can create a little trough or a little moat around that root without removing valuable bone. And so we do this on the mesial, we do this on the distal, we can do this on the palatal as well. There's always plenty of palatal bone to work with. I don't like to do this on the buccal because, of course, that's the important bone, is that buccal occlusal bone. But we can certainly do this, on any other side of the tooth. And, what prevents you from having to use this is my first tip is to make sure you have some mobility right before you start extracting the tooth. But of course, we do run into this problem once in a while. And so if you have this in your kit, this is, again, it's called an 859 Brasseler burr. It will save you hours and hours and lots of sweat and tears over the course of your career. I can tell you that. So using these two tools, I can almost always get a tooth out without having to even use a luxating elevator like you see here. I do like to have these in my kit. They're very valuable. It's basically an elevator that has a very thin tip, and that allows you to get into that PDL space and create a little bit of leverage. But in most cases, like I mentioned, I would rather not put all that trauma on the soft tissue. I would rather be able to have some access to be able to grab that root with my ash forceps and extract the tooth atraumatically that way. Now, talking about bone grafting, this was an article that me and one of my very good friends from my periodontal residency did, and this was very popular back in the early 2000s. This discussion of extracting teeth placing implants immediately without bone grafting. Again, this is a Dennis Tarnow philosophy here. And we decided, let's do that for a posterior tooth. Let's take out the tooth as atraumatically as possible without a flap. Let's place an implant into the septum and let's not bone graft. And back then, I wasn't such a photographer, but my good friend Dr. Gober was. And what he did was he took photos every week, and we took a bunch of these photos and we submitted them for publication. And it's really amazing to see how you can see on the lower left side of your screen at 1 week, it almost looks like this implant's going to have no bone around it. It's not going to heal. You see at the 1 month, soft tissue has granulated in over the site. At 2 months, you can almost not see the implant anymore, right? The soft tissue has gone even further. And then we were able to do the uncovery here to actually see how this healed. And sure enough, we did heal with bone around that implant. And again, this goes back to what we first started talking about. The body wants to heal. But I will tell you, when I look at this case now, 20 years later, to me, while it's certainly clinically acceptable, we do get resorption, right? We do get resorption, and practicing in private practice, I'd like to be a lot more confident that that bone is going to heal and that we're going to have that, bone contour. And so while theoretically this sort of treatment works, in my practice, I don't like to do this. I want to be a little bit more certain that I'm going to have great bone around my implant. And in order to do that, we have to maintain that blood clot. We have to maintain that space. And I do that with bone grafting. And there's a lot of, religious thoughts about this, right? So this is like a philosophy issue. And I will tell you that, there are plenty of studies that show that socket grafting at the time of extraction will give you a larger percentage of bone around the future implant site. And when you look at the numbers, it's not like mind-blowing numbers. Don't get me wrong, 1.6 millimeters for cases that were bone grafted, right? In more bone for cases that were grafted versus not. But let me tell you, we're dealing in millimeters. We're implantologists. We're talking about we needed to place a 4 millimeter implant. Well, the difference between me being able to feel confident placing that 4 millimeter implant and not violating that critical bone thickness we talked about is usually that 1.6 millimeters, right? And I will tell you also, this is really a patient management issue because there's no situation where I bone graft a patient and guarantee them that I don't have to bone graft it again later. Okay. Because everybody's going to heal differently. Some patients start off with very thick bone. Some patients start off with very thin bone. And I love the saying, you need money to make money. Well, you need bone to make bone. And so it's certainly going to be a lot easier to preserve a patient who has very thick bone than it is very thin bone. But again, we don't know who to treat. And so I'm going to show you how we treat sockets as atraumatically as possible. But I think it's important to note that, even if we have to go back later and bone graft again at the time of implant placement, it's not a failure, right? It's us being as preemptive as possible, trying to minimize the number of surgeries, trying to minimize the morbidity because the patient is ripe for healing at the time of an extraction. And so to me, that is the time to perform these socket grafting procedures. And I think, it's important for me to discuss, these patients come in and many times, we are doing a true preservation procedure, and I'll code that as a 7953. Other times, these patients are coming in for a tooth extraction, but they have a complete loss of the buccal plate, as you see here, due to this root fracture. And once we finish degranulating this site, these patients are left with very large defects. And maybe the patient has very thin anatomy to begin with. So we're really having to try to regrow bone outside of the housing. And I don't necessarily code that as a 7953 because I'm growing bone outside the housing. I will code that as a ridge augmentation at the time of tooth extraction. And so very important to just follow a very strict protocol. 15 blade to sever the PDL. I do that in every single case. Don't be afraid to section teeth, especially molars. We kind of think to ourselves, I can just grab it. It looks like there's a lot of bone loss. I can't tell you how many times I've taken out perio-compromised teeth that even had mobility. But you start trying to grab it without having some good, path of draw and good mobility of the tooth before you grab it with a forceps, and then the root breaks. And now you're dealt with a situation where you have no access. You can't see. And so, of course, you need to have good lighting, but you also then have to usually raise a flap. And now we've just broken the rule, right? Now we're raising flaps when we really didn't have to raise flaps if we were a little bit more patient. So again, slow is smooth, smooth is fast. Once I do get that tooth out, the first thing I'm going to do is I'm going to bone sound from within that socket. And I'll typically even do that with my spoon, curette, right? So I'm going to start degranulating and bone sounding. And if my buccal plate is intact, then we're in really good shape. We can either place our immediate implant or we can even just, graft that socket without having to raise a flap. There are instances where maybe the buccal plate or the residual buccal plate is very, very thin, or of course, maybe we have a very large infection, we need to get access. And in those cases, I will raise a flap. But I really try to do that after the tooth is extracted. I very rarely make a decision to raise a flap before I take the tooth out. I always want to get that tooth out and evaluate the socket before I do that. And I think it's important that we all understand that you cannot bone graft a site or even expect good healing from a site if we're not removing all of that infected tissue from inside the socket. Now, I know nowadays there's a lot of in vitro studies that are talking about how chlorhexidine, using that in the socket, can inhibit fibroblast growth. I will tell you in all the cases that I do, I always irrigate with Paradex or chlorhexidine. I find that it is very effective to sort of have all of that granulomatous tissue kind of congeal together. It makes it a lot easier to degranulate. And the other trick, again, is to be very systematic in your approach. I don't like to take a spoon curette and just start blindly curetting. I will actually work my way around the socket. Okay. Work your way around the socket with the back end of the spoon and start peeling off any of the soft tissue around the walls of the socket, and then go back into the bottom. And you can usually scoop everything up in one fell swoop and then irrigate very, very well. And then my next tip for those of you that are getting into bone grafting is, again, we need to make sure that socket is very, very clean. So never assume that you've gotten it all, right? We want to feel back into the socket, see if we can feel anything soft. And more importantly, we want to look at the socket with our eyes with very good lighting to ensure that we didn't leave any soft tissue remnants behind. One of the things that I often find is if you're bleeding a lot from a socket, yes, that's a good thing to have good bleeding. But if it's bleeding a little bit more than normal, there's a very good chance that you still have some granulomatous tissue hiding somewhere. And in some cases, for instance, if I'm treating a molar that maybe had a large infection in the septal area, it may be very difficult to get that soft tissue out because maybe it's hiding under the furcation. And I will actually remove that septal bone if I need to get access to it, right? Because not all bone is created equal. I don't want to remove the buccal bone, but it's very important that we degranulate this site. If I can't completely degranulate it, maybe I'm working very close to the mental foramen or the inferior alveolar nerve, or maybe close to the sinus. In those cases, I will irrigate very well after doing some gentle degranulation, and then I'll let it heal. So that's one of those situations where I won't graft. But in most cases, I can spend some extra time, an extra 5 or 10 minutes, and degranulate and irrigate very, very copiously and feel very comfortable that that socket is clean. And then we want to make sure that we have bleeding, right? So it's that slippery slope. We don't want too much bleeding, but we also don't want the site to be dry. And I think that's the biggest mistake. If we're over suctioning that socket and we're maybe taking a long time during the surgery and we're using, an air driven handpiece, which is obviously a big no-no. You always want to use a surgical handpiece when you're working on the bone. You can get things to be very dry, and that is not good for healing. And those are the cases where, I will, and it's very rare, but there are cases maybe once a week where I will create intramural penetrations into those socket walls to create a little bit more bleeding. And at that point, then I can perform my grafting. And so there's so many different materials we can use for bone grafting. And of course, a lot of us, are so used to using particular graft, and that's okay. But there are times when we don't have to do this. Again, what we're trying to do when we're doing socket preservation is we're just trying to, provoke the body to do the healing for us, like I showed you in one of the first slides. And I will tell you, I also have a lot of patients that don't want to have allograft. Okay. And so if I'm working from within a socket that has the walls intact or even a mild or moderate dehiscence, but good bone anatomy, we can use other materials such as the OsteoGen plug. Okay. So there's a lot of different materials on the market that look like this, and a lot of them are collagen sponges. I really don't like it to be very, general about this, but most of those materials are going to resorb very, very quickly because they're basically just collagen. The OsteoGen plug I've been using for many years, I don't post about it a lot because these are sort of the very simple cases, but I'll show you some examples of it. But what this is it's a calcium phosphate interspersed with some collagen, some type 1 collagen. And so it holds the space very well. It's bioactive. It allows the body to do the work for us and maintain the space. And so as you see here, we're extracting that tooth as atraumatically as possible. In this case, the patient had good anatomy, but the buccal plate was very thin. And then I have a decision to make. Do I raise a flap and turn this into a proper ridge augmentation, procedure at the time of tooth extraction? Or can I just preserve the defect there and try to minimize the shrinkage by using the OsteoGen plug? And so that's what I decided to do here, as you see. And so the OsteoGen plug gets inserted right into the socket. We have good bleeding, so we allow the blood to work its way through that material. It's a very hydrophilic material, so it only takes a couple of seconds once the blood hits it for the consistency of the material to sort of change and to become very almost like congeal with the blood. And then I'll use a bone plug, to very gently compress this. We don't want to over compress it like we would with amalgam, but we just want to kind of compress it so that it fills the voids. But again, because of the quality of the material, it is sucking up the blood and it almost will expand into any of those nooks and crannies. And then I don't have to get primary closure. That is the biggest thing that I've learned, and I did luckily learn that early in my practice, not to fight for primary closure. There is no way to get primary closure here without pulling the soft tissue and maybe even making a periosteal releasing incision. And again, that all that is doing is creating unnecessary trauma. If we have an intact socket and we're using a bone graft material like this that is holding the space, I will put a suture not to pull the gum closed, but just to help keep the bone graft into place, right? So this is a single interrupted suture or maybe a cross mattress suture that is just lying over that membrane in a crisscross fashion. Just lying over that bone graft. There's no membrane here. And it's just sort of in a crisscross fashion, just to prevent, the material from being sucked out from the patient that maybe will disturb the area or maybe accidentally brush the area or get food in the area. It's just helping to keep that material in place. And the way this heals every time at about 3, 4 months, I have new keratinized tissue that's now migrated over the area. And as you can see now, I have great bone. I can place the implant in the perfect position. Did I get a little bit of resorption, as you saw from the previous photo? The soft tissue maybe collapsed a tiny bit. Sure, that we did get that because again, we had a very, very thin buccal plate, but I basically preserved everything within that bony housing. And so we have plenty of bone now to satisfy that critical bone thickness. And I can, kind of account for the fact that I had that little soft tissue defect by doing what you see on the right side of your screen. When I'm placing my incision to place my implant, I'm placing that incision just slightly lingual to the mid crest, right? Because then I can move that keratinized tissue from over the occlusal aspect to the buccal side and going to be placing a healing abutment. And so now we can kind of get a little bit more of that soft tissue bulk onto the buccal side. So we put this video together just to show really how simple this can be and just to show those that haven't used this material this behaves a lot differently than a collagen plug, right? So people will sometimes look at it and say, "Oh, it's just a collagen plug." If you use a collagen plug, I use collagen plugs all the time, and I use them, to be honest, as you see here on the screen. That's a simulation that we were doing soft tissue grafting harvest, right? And I will place that collagen plug in the donor site of the soft tissue graft site on the palate just to help hold the blood clot. But that material is like gelatinous. It really wants to, wash away. This material is a lot stronger, okay? And so I'm illustrating here how the handling is when it's dry. Very easy to handle. We can actually cut the material if we're dealing with a molar site. We can cut the material and then actually have, the material that will go into all those little nooks and crannies of the root. But the material does expand, and once it gets wet with blood, which I'll show you in a minute, it really wants to fill all those voids. This is also a great bone plug. It has a small and a large tip, and I'll use that just to very gently compress the material right to the level of the osseous crest. We're not expecting bone, to be regenerated coronal to that. So there's no need to have this material really being pushed coronally to that. So once I have that material in place, I'm going to be placing some sort of very simple suturing. As you saw here, I went from inside of the socket to outside of the socket when I did the suturing because I didn't want to be pulling the material out of the socket. I like to call this a cross mattress suture, but you don't have to do anything like this. It doesn't have to even be this fancy, even though this is very simple. All you have to do is place two single interrupted sutures, in a crisscross, and that'll work just fine. And so I showed you how the material handles when it's dry. If you put some simulated blood, or of course, blood in the real mouth, what happens is you see how hydrophilic the material is. And so within seconds, it really gets congealed very, very nicely. It loses some of its firmness, and then you're able to compress that right to the level of the osseous crest. Again, not over compressing. We're just compressing it just enough so that it fills those voids and that we don't have to start cutting the material. And even in the diagram I showed you, I showed cutting the material just to show that you can, if you're dealing with a small socket and maybe you only have a large plug, you can certainly cut the material, but you typically don't have to because once it gets wet with blood, it will sort of compress on itself. Okay, so you see here, now this is just a cross mattress. Again, you don't even have to be this fancy. You can just place a couple single interrupted sutures. I typically do like to use a suture that will last a little bit longer than a week or so, just because I know how long it takes soft tissue to migrate over. It's going to take about a week to 2 weeks. Soft tissue will migrate at about a millimeter a day. So we really want to give it some time for the soft tissue to migrate over, and that, reduces the risk of losing some of this bone graft material. Now, if those of you that are looking at this saying, well, why don't you just use particulate? Well, you certainly could, but remember, number one, it's more expensive. Number two, it's a lot easier for that particulate bone graft to start getting loose in the mouth and freed up in the mouth. And that's what I found is that, if I'm placing particulate without a membrane, most of that material is going to be gone in a couple of days. And so you end up with almost like a crater defect at the site. How important is that? I find that most cases, it's important because then you end up losing a little bit of the bone height, and it just takes a lot longer for it to degranulate over. So if I can maintain the space using this type of material, I think you're going to be a lot better off. And so for these cases where even when patients have this thick bony profile and you say to yourself, well, maybe I don't need to graft it. If you have a material that's very easy to use, that's bioactive, that's not causing any inflammatory reaction, but will allow you to hold the space, that's what I'm going to do. And you can see I just got this photo last week on one of these cases. This is just a 1 week post-op, but you see in 1 week, look how much soft tissue has migrated in over that site. And so I didn't have to raise a flap to pull things closed. We're actually regenerating soft tissue with this sort of a technique, in addition to preserving the bone, because soft tissue will migrate in over the graft site. Immediate implants, you can certainly use it as well. You place an implant, like I had showed earlier on, you have this horizontal defect, and studies show that could you leave that defect to heal on its own? Sure. Would I do that if I was in training in dental school? Yeah, I would maybe do it to see what would happen. But in real life, I don't want to do that and risk having, everything resorb and then having implant thread showing and then have to deal with going back later for a bone graft or a soft tissue graft. I want to close that space. I want to maintain the space, and using a bioactive material like this that's very biocompatible without even suturing in this case, because that gap is so small, right? That I'm very confident that material is not going to be coming out. And you can see here at 1 week, what happens to that soft tissue? It migrates to the healing abutment. And now we have beautiful healing. So, these are cases that we see day in and day out. The socket grafting is probably my most common procedure. I wish every case was like the ones I just showed you. There are many cases that end up being a lot more complicated because we have a larger defect. And like I mentioned, if I have a mild dehiscence defect or even maybe a moderate dehiscence defect, but maybe the patient has good ridge width and good anatomy, I will still use the OsteoGen plug, but maybe I'll lay a collagen membrane over that buccal occlusal line angle. These cases I'm showing you here just to show you the sort of the spectrum of, maybe a mild dehiscence like you see on the upper left side of your screen. So it's a mild dehiscence. It's very narrow. It's relatively deep, but it's very, very narrow. Whereas, other cases, I'm going to have a more moderate dehiscence where, it's a little bit wider. And then there is this, class of procedures where we have much larger defects, like you see on the bottom side of your screen. And those are the cases where I'm typically flapping things open and maybe performing a more traditional ridge augmentation procedure. And so we'll talk about that now. So how am I making that decision? Well, we talked already about the past principles, and it's important to understand that the past principles are for ridge augmentation. I can't make that more clear. If we're just trying to preserve what's there, you have to understand we already have blood supply from the defect. We have a socket that we're grafting into, so we have walls. And so we don't necessarily need to stabilize because the shape of the socket itself and those residual walls are helping to maintain the space. Now, I do want to put a bone graft in there to support it, but using a membrane here is very easy to do. We don't typically have to stabilize the membrane, but I do like it because it will isolate that defect from the soft tissue and give me the best chance of regenerating the most important bone, which is the buccal occlusal line angle. And that's typically the bone that's lost once the tooth is taken out. And so I just want to really highlight that if I am extracting a tooth atraumatically, like I had just talked to you about, and following that protocol very, very strictly, and then I start bone sounding, even if I have a dehiscence, I am not rushing to raise a flap. I can raise a very minimally invasive flap or a little tunnel if I need to, as you see in this case, and I can slide a membrane into that space, pack bone into the buccal occlusal line angle. That's the most important bone. Look how far I pack bone. Maybe too much, right? But that's really very important, is to use enough quantity of bone. You don't want to pack bone into a socket, but not have the volume be maintained. So you have to make sure that you're using enough bone, and I will overbuild it and overpack into that buccal occlusal line angle. But that membrane was placed in first, right, to isolate that defect. And you can see how this heals. This is now at about 4 months, and soft tissue has migrated over. And I re-enter the site with a papilla-sparing incision, and you can see that bulge that I was able to preserve. Okay, so even though I had a dehiscence here, I didn't raise a flap. I used a tunneling spoon. I'll show you a picture of the tunneling spoon that I use in just a second. This is really the most valuable tool for soft tissue grafting that I have, is using this tunneling spoon, because even for most of my connective tissue graft cases that I do nowadays, I'm tunneling, I'm not raising flaps. And so this instrument just allows me, it has a great angle. It has almost like a spoon-shaped tip, but it allows me to reflect the periosteum off of that bony defect. Okay. And then I can also slide my membrane into that defect. So it's very important, if you're planning on using a membrane when you're tunneling, to make sure you're tunneling laterally to that dehiscence defect on either side, so that your membrane can slide in very, very nicely. If you don't, or if you under prepare your tunneling, when you go to put your membrane in, it's going to be a huge headache, because the membrane is going to be folding up on itself, and it's not going to be lying down nice and conform to the defect. Okay. Now, what cases do I raise flaps? Well, there are many times when you just cannot degranulate effectively without a flap. You sometimes do need access. And also, if you want to grow bone outside of the housing, if the patient already has a very large defect and you're performing a more traditional ridge augmentation at the time of tooth extraction, well, then we certainly benefit from raising some sort of a flap. And I just want to reemphasize, just because we're raising a flap doesn't necessarily mean that we have to pull things closed. Okay. And I'll show you that, because yes, we do like the idea of getting primary closure from the perspective that, okay, we're not going to lose bone graft material. You have less risk of contamination from saliva and bacteria. But in order to get primary closure, it's much more technique sensitive. You have to be able to do a periosteal release atraumatically. And that is not necessarily something that everybody's comfortable doing. If we allow the body to do most of the healing on its own and not really fighting for primary closure, we're going to, yes, have some bone graft or some of the OsteoGen plug exposed, okay? But we know this material is very biocompatible, and soft tissue is going to migrate over the site. Now, no matter which one of these options that you do, it doesn't mean that you're never going to have to bone graft a second time or soft tissue graft in the future. But I found that if I can preserve the soft tissue, then worst case, I have to maybe add a little bit more bone when I place my implant. but I usually do not have to go back and do soft tissue grafting. And I love showing this case because this is a perfect example of me early in my career being a little bit too aggressive and taking out teeth that were periodontally compromised. They did have a lot of bone loss. And so I was very focused on the bone grafting at the time of tooth extraction. And this is how the patient presents for their implants. And the CT scan looked amazing. I was super excited. I get in the patient's mouth and I say, whoa, what did I do? How am I going to fix this? And so you'll see here that I like to call this the self-inflicted mucogingival defect technique because this is me being way too you know easy to do that periosteal release and pull the mucogingival junction. We don't have to do that in most cases. Why did I do it? Again, I was focused on the bone. And did we get bone? We sure did. But then I had to go back and do some sort of soft tissue grafting procedure, either a free gingival graft or little bit more nuanced technique like you see here. This is called the modified roll technique. So I'm creating a little trap door on the palate and I'm taking a little soft tissue pedicle, folding that to the buccal side and supporting that with healing abutments. I don't like to do this. I don't want to do this. I would much rather be able to just do like a roll technique and place a crestal incision and move the tissue to the buccal. But I couldn't because I had completely moved the mucogingival junction. So I was able to get the case back to some semblance of normal anatomy. But you see, I still have that muscle attachment up there, which I'm considering going back and now, releasing. And it's all because I fought for primary closure. So I really have to emphasize just because we're raising a flap to maybe get access or to grow bone outside the housing, I am much more comfortable leaving things exposed, even in a case like this where I have a very large socket and a large buccal defect. I'm placing my membrane, I'm packing my bone into that buccal occlusal line angle, really trying to preserve the dimensions of the ridge. And I would rather let it heal because what's going to happen? Again, the soft tissue will migrate over the site. Okay. And if we're using, materials that are non-compatible or cross-linked with chemicals and things like that, sure, there may be an inflammatory reaction. But if we're using collagen membranes that are not cross-linked with chemicals or glutaraldehyde, they are very biocompatible and the body wants to heal. So soft tissue migrates, again, about a millimeter a day. So within 2 to 3 weeks, a big socket like this is completely filled with not only immature bone that will eventually turn into bone, but we've actually created more keratinized tissue without moving the mucogingival junction. Now, as I promised, I'll share some ridge augmentation tips as we get close to the end here. But ridge augmentation is sort of a different beast. I showed you already how I like to perform these procedures, but there's a little bit more you have to think about. You have to, create blood supply. We talked about that already. And we have to make sure that we're stabilizing our membrane in most cases. If you have a very concave defect, you might get away without having to stabilize the defect or the membrane. But in most cases, we really want to confine the bone graft to the defect, and we want to stabilize the membrane so that there's no micro movement during healing. And that's how we're going to get, really predictable ridge augmentation. And so I always show that when I do ridge augmentation, I will create these intramural penetrations. I want to create a lot of bleeding at the site. I'll also harvest autogenous, completely different than sockets. I've never harvested autogenous bone for a socket graft, right? We don't need to. There's great blood supply. But for ridge augmentation, I do. And that really drives my decision on where I place my incisions for ridge augmentation, because many times if I can just extend my incision a little bit more distal, for instance, in the lower in the mandible posterior, I'll do like a distal releasing incision and I can harvest with a scraper some autogenous bone. And then we mentioned you have to really consider stabilizing a membrane. And so this is called the sausage technique, which was developed by Istvan Urban, and it involves using screws or tacks, which is what he prefers, to be able to really compress that bone graft and confine that bone graft to the defect. And he calls it the sausage technique because it looks like a sausage. That membrane gets stretched really nicely. And so I do like using this technique, but I also showed you earlier, I like using the stabilization sutures because I find it's a lot easier. And in most cases, I can get, plenty of stabilization with just using the sutures and not having to use the tacks. And so here's another example I've showed already using the OsteoFlex membrane. This is a pericardium membrane that has great handling. And why I love it is because I can use it not only for this stabilization technique with sutures, but I can also use it for stabilization with tacks. So here's a couple of cases just illustrating that. This is a sinus augmentation case, and it was really one of those in-between cases where I was thinking about doing a internal sinus lift. I really didn't have great access, and I wanted to do a soft tissue graft simultaneously on the tooth in front of it, and we decided to do a delayed approach. And so I created a lateral window. I always do that with a piezo. I elevated the sinus membrane, and then I grafted the defect. And one of the things I love about this membrane is it actually comes with a template, and you don't have to be worried. Some of the other materials or other membranes that I've used do come with a template, but it doesn't say template on it, so you're not really sure that it's the template. This is one of my biggest tips whenever I teach my bone grafting course is to use a template. Membranes are not cheap. They're expensive. And once they start to get hydrated with blood, or we start trimming the membrane, we over trim the membrane cannot confine the bone graft. And we can't really stabilize the membrane because we don't have enough of it. So I love using the template. I use it in every single case. I will create a template and know exactly what size membrane I want. So this comes, packed into the packaging. It's sterile. So I can take this to the mouth and I can, really make sure that I have the perfect size. You can use this membrane wet or dry. I do prefer to put it into the mouth dry, get it where I want it. And you can see because it loses its memory completely, it will suck down over the area very, very nicely. Now, some of you are saying, well, that's perfect. Just close it up and move on with your day. And you certainly could in a case like this, because if you take a couple of seconds and adapt this right where you want it, it's very hydrophilic, this membrane. And so the blood will sort of congeal and it will sort of suck down over the defect. Now, for illustration purposes, I'm showing you here that I'm actually stabilizing in this case. In most cases, I do stabilize because it's so easy to do. I've already had to do a periosteal release to be able to get primary closure. And so I have the apical periosteum, which I'll show you in a second, that I can use to stabilize this. So it's very easy to do, especially with this membrane, because it does sit down and kind of hug the bone very, very nicely. But you can see here with the flap retracted that I'm actually biting the apical periosteum. That's what we're biting to hold this membrane in place. And then, of course, we're getting primary closure. And you can see the postoperative x-ray that we took just to confirm that the membrane was intact. Okay. What about a little bit more complicated case? Here's a ridge augmentation case. Again, tooth extracted. Actually, I don't think this tooth was extracted. I think this was a congenitally missing lateral incisor, now that I'm thinking about it. And when you look at this, it really shows that, right? So the body is very smart. We don't have a tooth there. There's a very large defect. And so this patient had actually been wearing a Maryland bridge for many years. He was waiting till he was in his 20s. I think that was great advice that he had gotten when he was younger. But now it's ready for the implant. So he comes in to see me and we take a CT scan, and of course there's not enough bone. So in this case, it really highlights the versatility of this membrane, because what I'm able to do is I was stabilizing it with a screw, and I did that apically here. I also have a screw or a tack on the lingual aspect, which is usually the one I place first. So I'll take the membrane to the mouth dry after sizing it with the template, and I'll usually place the tack or the screw in the more difficult site first, which is almost always the lingual or the palatal. And so I did that. I placed that tack on the palatal. Then I'll pack my bone into the defect, and then I'll fold that membrane over the bone graft. And I placed one more tack. Now, as I'm trying to place that second tack to the left, I was running into the tooth. I over trimmed the membrane, so I couldn't extend the membrane, medially at all. And so I have this little trick up my sleeve. I can just use a suture, right, to hold that membrane down. So that's what I did here. And that's really the beauty of it, is that you have the flexibility of using screws and tacks, or you can use sutures. For those of you that haven't really been able to visualize what I'm doing, basically I'm having to do a periosteal release because I need primary closure. And so this is how I'm doing a periosteal release. I'm using a fresh 15C blade. So this isn't the same blade that I'm using for my initial incision. This is a brand new 15C blade, and I'm only going a millimeter deep. I'm starting at one extent of the flap. So I always start at the distal, under any vertical incision that I had, and I'm just apical to the mucogingival junction. And so I'll show it again. We're just basically using that fresh blade, putting good firm tension on the flap margin, because that allows you to incise through the periosteum. And it's only a millimeter deep. Because why? Because all the blood vessels are deep. right? Deeper than the periosteum. We don't want to sever all those blood vessels. So the periosteum is only about zero point 0.6 to zero point 0.8 millimeters deep. So if I make an incision that only goes a millimeter deep, I'm incising the dense periosteum, and that is going to free up the flap without having to go any deeper. Now, this is a very technique sensitive procedure. You also have to be very careful of the mental foramen. And just to show it one last time, I'm being very, very careful. I can't emphasize that enough. You need to, really be experienced to do this. You need to visualize the mental frame and you have to be able to see it so that as I get to about 10 millimeters from it, I can move coronal to it. And in this demonstration, I'm probably too close to it. So keep that in mind. When you get 10 millimeters to that mental foramen, you can go coronal to it and then you can drop back down. And then I test my release. So after doing this initial incision, I get some release. But the beauty is that once I've incised that 1 millimeter depth through the periosteum, I can now stretch within that incision line. So I will grasp the flat edges with a forceps really firmly, and then I can use a periosteal elevator, or in this case, I'm using what's called a mini-me. So this is a micro elevator that has this nice angulation to it, and I can just pull and stretch that flap. So what that's doing is that's stretching the subperiosteal fiber bundles and creates the elasticity that allows you to coronally position. Now, this is for demonstration purposes. For most ridge augmentation cases, especially horizontal augmentation, you're not needing to create that much release, but it really shows how effective this sort of technique is, because you can almost see in the video all those deep blood vessels that we're not severing because we only incise through the periosteum. Now, the other thing to notice is look at where that periosteal incision was. And right under that initial incision, you can see that periosteum that's apical. Okay. That is what we're biting when we're doing our stabilization suture. And so we have our bone graft on the defect. We have our membrane that doesn't have any memory that's sort of sucked down over the defect. And then we'll can do these periosteal stabilizing sutures. And again, look what I'm biting. I'm biting that apical periosteum that's apical to where my incision was. And you do this very carefully. It wants to get hung up on every single thing. So my assistants have been working with me for years. They know they usually have like a perio probe or some sort of instrument that they're helping to guide the suture as I'm tightening this suture. And again, look, you see it's getting caught up again. So my assistant comes in, or I'll come in and just make sure that I'm right where I want to be, and then I can tie this off. So in this case, I started by going through the palate, and usually about 5 to 7 millimeters from the flat margin. I go over the membrane through the apical periosteum on the buccal side, and then back out through the palate, and then I'll tie it off. And that way my knot ends up externally. You could certainly do it by first biting the periosteum and then going through the palate and then back through the palate and then tying it off over the membrane. But remember, in that case, your knot is going to be internal. So you have to use a resorbable suture if you're going to be doing it that way. Okay, so here's the case. Again, I wasn't planning on using sutures. I was planning on using tacks, but because I over trimmed the membrane, I went ahead and did sort of a combination here and got that membrane to be very stable. You can see very easy primary closure. So the difficult part of these cases is not in getting primary closure, because we've already done a beautiful periosteal release that's released the tension in the flap. And so all it takes to get closure here is a horizontal mattress over the defect site, and then 2 or 3 single interrupted sutures for a small defect like this. And you see how biocompatible this membrane is, how beautiful the tissue heals. So now this is at 1 week post-op. I know it's only 1 week because those sutures are dyed sutures that lose their dye at about 2 weeks, and they're still relatively purple. So they're somewhere in between 7 to 10 days here. Okay. And then we're going to let this heal another 5 months, and beautiful, healthy, soft tissue. And here's our bone. All right. So we're able to place our implant again in a prosthetic position. I don't have to worry about, grafting again at the time of implant placement because we've filled that defect. And you did see that I do overbuild these defects. I do expect some shrinkage of these defects. Pay attention to the incision design. I love this incision design on the left side of the screen for anterior teeth. I'll go sulcular anteriorly and then a single distal vertical releasing incision. And why do I do that? Well, I can get access for harvesting autogenous bone. Okay. And so I will always harvest with a scraper to incorporate that with my allograft when I'm doing this type of bone grafting. And so beautiful outcomes, not only for socket grafting, but for ridge augmentation. If you follow the principles that I've showed you, I think you can get very, very predictable results. But the goal would be to try to avoid the ridge augmentation, right? Try to be as atraumatic as possible from the get-go. And I think you're going to find that you can be very, very predictable. Your patients are going to be happier, and you're not going to have to do as much of this soft tissue and hard tissue manipulation later on. So, this was a quick webinar where I tried to give you guys as much information as possible in 1 hour. So I think we did pretty good, but I'm excited to see any questions that you guys have, any things that I can clarify for you. I'm happy to stay on and answer. And again, I just want to thank Implement and Leslie for inviting me. And hopefully, if you guys have any ideas for future webinars, let Leslie know, and hopefully we'll be able to, satisfy that. Let's see here.
Great. Thank you so much, Dr. Fine.
Of course.
We do have questions.
Amazing.
Yeah, we do have questions. So the first question is, would using molecular iodine be better than chlorhexidine?
I don't have experience with molecular iodine. I do have a couple of oral surgeon friends that I work with that have told me that they do use iodine. Any sort of antibacterial is fine. I will tell you, I like the chlorhexidine because it really does congeal that granulomatous tissue. And for those of you that have never tried to use it in the socket, I will tell you, all of my socket grafts, even the ones I've showed tonight, I use Paradex, I use chlorhexidine. I do irrigate after with saline, okay? Just mentally, I like the idea of not having chemicals in there. But if you're ever stuck trying to degranulate a site, you take some Paradex, you put it into the socket, and you let it sit there for a couple seconds. When you go back to degranulate, it all comes up much easier. It's a much, much more effective way to degranulate than just using saline. And I know that there are a lot of, well, I shouldn't say a lot, there's a couple of in vitro studies. Those are tabletop studies that show that chlorhexidine may inhibit fibroblasts. But I will tell you from clinical experience and from all the cases I showed you, I do not believe that it's clinically relevant because I believe that, the amount of fibroblast, inhibition is insignificant because I have never had an issue, with going back and not having bone in one of these cases. I think if you're following the rules, you're cleaning the socket appropriately, and you have good bleeding into that site, it shouldn't be an issue. I know doctors that use a tetracycline slurry for cases. I know doctors that do use the iodine. If that works for you, I am not being critical of it. I just have never had a need to do that.
Next question. When the bone graft is placed, should you place clindamycin over it prior to placing the graft in the socket?
Clindamycin, is that what they said?
Mm-hmm.
So I have to say it. To me, clindamycin is probably the least effective antibiotic. And, a lot of literature has come out, talking about how clindamycin is really not recommended anymore. Even for patients that are allergic to penicillin, clindamycin is not the go-to. It's very bad on patients' stomachs. And I will tell you, there was a study from 2006. So this is dating me a little bit. This is when I was in residency. It was Barry Wagenberg. He looked at 3,000 implants that he placed, and there was a 3 times greater risk of implant failure in patients that reported allergies to penicillin.
Mm-hmm.
Why? Well, those patients were taking clindamycin. It's very ineffective. And I will tell you, for my rid, not for my sockets, for my sockets, I'll give a Z-Pak or even Omnicef. Okay. But for my ridge augmentation cases, I do not do those. If a patient's allergic to penicillin, I send them for an allergy test.
Mm-hmm.
And guess what? 150 or so patients, maybe 1 or 2 are actually allergic to penicillin. 10% of patients that tell you they're allergic to penicillin are actually allergic. And in my experience, the number is even less. And patients thank you. It's good to know if you can take penicillin. And every one of them says, oh, my mom told me I was allergic. Every one of them. Okay. You send them to an allergist. They give them I think that what they'll do is what I've been told what the patients get is like a skin test. They're not reactive. Then the doctor will give them a pill to take and see if they react. Zero patients for me. I don't know if I've had maybe one or two come back that they're actually allergic. So I don't do ridge augmentation if I can't give them a good antibiotic. So I don't give them clindamycin, and I have no benefit to me of mixing clindamycin with my bone graft. I don't do that. Now, what I do, very important, I get them on the antibiotics before the procedure. Okay. I think it's very important to get them on before the procedure. I think that's much more effective than even giving it to them after. Okay. And then if a patient calls me at the second or third day and they say, you know what, it's really affecting my stomach, I have diarrhea, I can tell them to stop because I know they were on it from beforehand.
Mhm. Okay, next question. Hi, Dr. Fine. Outstanding lecture as
Thank
always. This
you.
is Dr. Lander.
That's
Out of
nice.
curiosity, have you had differences in outcomes when hydrating the OsteoGen bone grafting plug, for example, in liquid fibrinogen versus using it dry?
I went through a phase, just like everybody, where I was very into PRF. Okay. I love PRF for sticky bone. It makes the handling of the sticky bone much better. But I don't know if it really improves clinical outcomes all that well. I know the reports are that it's good for soft tissue. After COVID, I was having a hard time getting the vial, the tubules, and I stopped using it. And I haven't noticed a difference. So I've really gotten away from it. I do think there's benefits for certain cases, like soft tissue cases. So I'm not really the best one to speak of for this. But think of it this way: if you hydrate in the fibrinogen, that it changes the nature and the handling of the osteogen plug. It's to me useless because I'm getting blood in the socket and I want to take it to the site dry and let that blood hydrate the material at the site. And so, sometimes less is more. And this is one of those cases. There's great bleeding from the socket, which is bone. We want that blood from the socket. We don't want blood from the patient's arm. I want blood from the site. So, I'm not knocking on PRF, and it's incredibly inexpensive and certainly good for soft tissue healing. And if anything, if you have access to, PRF, then go ahead, you do as I showed you, and just for a little improved soft tissue healing, lay a little piece of the PRF over the top, almost like it's a membrane, and then do your crisscross suture. All for that. But I think you're trying to, benefit, get a better benefit, but in reality, you don't need it. And so it just changes the handling. It makes it more mushy. I would rather take it to the site whole because that's really the benefit of the osteogen. It's the handling. You're using particulate graft, you got to scoop it, then you're losing bone in the throat. I mean, that's when I go to, that's for me. I don't have a lot of patients that, really give me a hard time about using an allograft. I do have some. I don't want to use a xenograft in a socket. I hate it. I don't think it turns over. I've seen many cases where years later patients come in and they had bone grafting done with xenograft, and you see the particles still there. So I don't want to use a xenograft. That's out of the question. So if I have a patient, that has a complicated socket and they don't want allograft, I would rather go to this. I'd rather go to OsteoGen. With that said, there's a lot of cases where the patients don't care, but I want to use it because it's just so much easier. Look, it's less expensive for sure, but it's also easier. It's fundamentally a socket graft that is going to stay in without having to worry about particles kind of flying out of the mouth and having these large defects. And it's bioactive. It works very, very well. You go back in into the sites at about me, I usually wait about 4 months, and I have healthy bleeding bone, as the case I showed you. So, I'm not using it in every case because there's some cases where I have a large buccal defect and I have to grow bone outside the housing. And because of the spongy nature of it, it doesn't hold the space as well as I could get a bone graft to hold the space with sutures stabilizing it and really overfilling it and compressing it. But I do use it quite a bit because, if a socket walls are intact and I don't want to raise a flap, I'm not using a membrane. It's just really convenient, without the compromise.
When using a membrane for dehiscence, are you putting the membrane inside or outside the socket?
Great question. So this is personal preference. I'm sure we've all heard of the ice cream cone technique. So we're trimming the membrane. This is Dennis Tarnow to look like an ice cream cone, and we're placing the membrane in the socket. I find that when we do that, we're missing the most critical part of the socket, which is the buccal occlusal line angle. Okay. So I put it outside of the socket. That is a great question. I will use a tunneling spoon if I don't have a flap elevated, and I put the membrane in between the flap, the internal aspect of the flap, which is the periosteum, and the bone. Okay. And then I can pack bone into that dehiscence, into the buccal occlusal lining. That's the most important area. That's the bone that we're really trying to preserve. The socket itself is going to heal with bone no matter what. It's that buccal occlusal line angle that we need. Okay. So I do that. I don't do the internal ice cream cone sort of technique. And I cannot, be more respect for Tarnow and what he does. It's just, it never worked well for me. So I don't do it that way.
The next question you pretty much answered. When would you recommend using primary closure versus non-primary closure during an extraction and bone grafting? I mean, we talked about it with the OsteoGen bone grafting plug that if the walls are in place, you don't need a membrane, but and primary closure.
Yeah, I think it's a really good question. I mean, there's a lot of nuance to it, but if I had to, summarize it, I think it's really patient anatomy. So if I extract a tooth in a patient who has very thin, skeletal envelope, and I'm really trying to grow bone outside of the housing, well, then I'm really doing a ridge augmentation. Okay. There are times when I do that and I leave it exposed, and I don't get primary closure, and I go back and I say, you know what, maybe I should have done a little bigger of a ridge aug, okay, because maybe I lost a little bit, but it was atraumatic, right? So again, that's like a patient management issue. So 9 times out of 10, I'm leaving it exposed. Okay, 9 times out of 10. When I'm certainly getting primary closure, large sinus communication, maybe. Okay, maybe those are cases where I'm pulling it closed because I don't want, I want to obturate, that communication. But most cases, unless I know for certain the patient has really thin skeletal envelope and I'm having to grow bone outside the housing, I'm trying to do a preservation as opposed to an augmentation.
Okay. Can you please share the suture needle size that you use?
Ooh, I don't know. I don't know offhand. Let me see if I can pull it really quick from someplace. Those are resorbable sutures. Okay, it's called polygalactoprone, and they break down with hydrolysis. So it's a really nice suture because um, I don't have to remove them. They last about 6 weeks. You can get them in a clear or a dyed. I highly recommend the dyed version because the clear are very difficult to see. And I'll use either a 5.0, or nowadays with my loops, I'm usually using a 6.0. Okay. But certainly, that's a little bit of personal preference, in terms of the size of the suture and what you're comfortable with. For thinner tissue, definitely the 6.0. For thicker tissue, I would go ahead and use the 5.0. If you give me a couple minutes, any more questions, I'll see if I can pull the packaging. I have it in a different presentation here.
So you stated you have your patients take antibiotics prior to treatment. Would the patient be at risk for C. diff?
No, because we're not doing clindamycin.
Yeah.
I start them on amoxicillin. Typically, a day before, I'll have them start using amoxicillin. If they have separation, that's the type of case where I'm not grafting. It's just not worth it. I don't want to put in, materials when I'm not sure that, the infection's under control. If you start doing this, you'll probably have what happens to me is most patients don't start it the day before, even though you tell them to. So in those cases, what I end up doing is I end up, having amoxicillin in the office, and I'll give them their first dose while they're in the office. Um, you know, 20, 30 minutes before we start the procedure, and at least they get that first dose in them. But I try to have and I'm getting better at this, trying to have, my office staff remind patients to take it, beforehand, because it does make a difference if it's in their system. All right, I just pulled that suture. So I use the DSM 13. is the needle. It's a 3/8 premium reverse cutting. This is sold by a couple different companies. Salvin sells a version of it. It's called Monoderm. I think Osteogenics, I know, sells a version of it, and it's called Glycolon, for what it's worth. Um, if you're, haven't used a lot of different sutures, Vicryl will work for this, probably a little less expensive. I really like PTFE, even though it's non-resorbable, it's super easy to use, very biocompatible, okay? And I know that it's going to be in place, right? So if you're first getting into this type of grafting and you're not really that experienced, use Glycon. Use PTFE. It's very easy to suture, very easy to use. You just have to remove it. And typically by 2 weeks, the patient comes in, one little cut, and it slides right out.
And let me see. If the socket's intact and you use particulate bone, do you need to tuck the membrane over it into the buckle, or do you use the collagen plug on top?
So very similar, whether or not, I'm using OsteoGen or if I'm using particulate, if the buccal plate's intact, then I'm not really tucking. I'm not using a membrane, right? If the buccal plate's intact, unless it's extremely thin, in that case, then I'm gonna create a little tunnel and I will try to pack bone to the buccal occlusal line angle. But in most cases, if the socket's intact, that's when I'm going for the OsteoGen plug to get away from using particulate because you don't need it. You have, contained defect with good bleeding and a material that will hold the space. I don't put a collagen over it. It's a very biocompatible material. And even if I was just using particulate, I would just leave it exposed. For those of you that use PRF, great time to maybe just put PRF. It's probably unnecessary. I know it's unnecessary, but maybe to help you sleep better at night, and not worry about losing any of the particular graft, you could do that.
Okay. Do you ever I would think you kind of talked about this. Do you ever prehydrate your osteogen plugs prior to placement, i.e., autologous plasma?
Again, I don't because I just find it changes the handling of the material, and the material is very hydrophilic. So maybe the one exception, okay, I don't do this because I stopped using PRF. But if I did have access to it and I had a socket that was not bleeding, okay, you maybe create some bleeding points, but you're still not having much bleeding. Maybe that would be a good example or a good time to do it. But again, I kind of want blood from the bone, not from their arm. I don't know. Maybe that's just me overthinking it, but I really think I like the way that the material handles dry. That to me is the benefit of it. I can take it right to the site dry, and it's so hydrophilic, takes 30 seconds, and it's filled with blood.
Okay. I think that because of time,